Welcome back to the continuation part of February 2010 paper 2. Now we will continue with the remaining questions now. Okay. Now next question is vasectomy. Vasectomy, you can see in this diagram also. What is vasectomy? Vasectomy is a method of permanent sterilization. It is a method of permanent sterilization, obviously in males. In females, we are going to perform tubectomy, whereas in males, it is vasectomy. Now, this vasectomy is a daycare procedure. Vasectomy, when compared to tubectomy, is a much easier procedure also. Okay. Now, what is the structure which is cut in vasectomy? You can make out in the diagram also. Vas deferens is the structure which we are going to cut in case of vasectomy. Okay. So after surgery, I will ask the patient to wear something called as snug underwear, or you can also wear something called as jock strap. In Hindi, something we will call it as langota, like something like is there. We have to ask the patient to wear that after the surgery. Not only that, will the patient get sterilized? The answer is no. There are already the sperms which are already present, and there is a chance to get a pregnancy as well. That is the reason why sexual abstinence has to be maintained. Sexual abstinence has to be maintained for few weeks. Okay. Now, what are all the complications you are going to expect in this? Obviously, any surgery you will expect bleeding, and you can expect infection. But where is this infection? At the incision site. At the site of incision, we can expect infection. Now, sperm granuloma formation, sperm autoantibody formation. These are all the complications I can get. Now, one more thing I want to mention is, what is the most common cause of failure of surgery? What is the most common cause of failure of surgery? It is misidentification of vas deferens. During surgery, if you identify some other structure as vas deferens and you are going to cut that structure, that is the most common cause of failure of this surgery. Otherwise, this surgery is a daycare surgery, very easy to perform when compared to tubectomy. Now, the next question is antisepsis and asepsis. I don't want to teach you all these things. Antisepsis and asepsis almost mean the same thing. There is not much of a difference between them. You can remember those routine things. Dressings is there, antibiotics is there, wearing gloves, cleaning, sterilization, autoclaving, all these things already mentioned. You can just go through. Nothing much to discuss over there. Now, acute pancreatitis question they have asked. I want to deal acute pancreatitis in a separate module. It is very important topic. For now, I am leaving. In the next module, I am going to discuss acute pancreatitis in toto. Now, coming to the next question, that is the surgical anatomy of the thyroid. Coming to the thyroid, here what we are going to see? Here you are going to see the veins. So here it is the superior thyroid vein here. Here it is the middle thyroid vein. Here it is the inferior thyroid vein. Okay. Now what is the arterial supply? Here there is superior thyroid artery. Here there is inferior thyroid artery. I want you to remember superior thyroid artery is a branch of external carotid artery and inferior thyroid artery is a branch of ICT. I want you to remember those. Now venous supply over, arterial supply over. Now we will look at some of the nerves. You can see a nerve over here which is over this part. So what is this nerve? Sorry, just a second. So what is this nerve? This has to be your external laryngeal nerve. Whichever is superior, it has to be external laryngeal nerve. And the nerve which is going to be inferior, this has to be your recurrent laryngeal nerve. Okay. And one more thing I want to mention is inferior thyroid artery is the one which is supplying thyroid, I accept, inferior pole, but it is also supplying parathyroid also. Okay, parathyroid is something which is going to supply the inferior thyroid. Parathyroid is supplied by the inferior thyroid artery. So in total what we have seen is three veins: superior thyroid vein, middle thyroid vein and inferior thyroid vein. If you carefully observe, inferior thyroid vein is going to directly drain into the brachiocephalic trunk. Okay, so now superior thyroid artery is a branch of external carotid, inferior thyroid artery is a branch of ICT. You have seen two nerves over there. One is external laryngeal nerve and the other is recurrent laryngeal nerve. Superior one is external laryngeal, inferior one is recurrent laryngeal nerve. And moving ahead, now tell me, what is the functional unit of a thyroid gland? Thyroid has lobules, right? This lobule is the functional unit of a thyroid. This lobule which is there is going to be supplied by a single arteriole. Okay, this lobule is going to contain what? Follicles. Around 20 to 40 follicles are there within a lobule. So if you remember follicule, these follicles are going to contain what? Colloid in their center. So follicles are going to contain colloid. Within the colloid, what is the substance which is present? Thyroglobulin. Very good. Thyroglobulin. Next, coming to the arterial supply. Thyroid is going to have a rich arterial supply, right? And there is going to be extensive anastomosis. Extensive anastomosis between what? Between the main thyroid arteries. Between the main thyroid arteries and the branches of tracheal and esophageal arterioles. Okay. Not only the rich arterial supply, thyroid is going to have an extensive lymphatic network also. Under lymphatics, they are going to drain into one deep cervical lymph nodes. Okay, deep cervical lymph nodes. Not only that, they are going to drain into delphian and paratracheal lymph nodes. Especially which are present in the subcapsular plexus. So lymph from the subcapsular plexus is going to drain into where? Delphian and paratracheal and Some are going to drain into the deep cervical lymph nodes. Coming to the recurrent laryngeal now. In the surgical anatomy of the thyroid, the most important part is this, that is the recurrent laryngeal nerve. Recurrent laryngeal nerve on the left side, due to the presence of the arch of aorta, it goes beneath the, it recurs around the arch of the aorta and it is going to come up. But whereas on the right side, it is going to recur around the subclavian artery. So when it is going to recur below the arch of aorta, round the arch of aorta it is going to recur, it has to travel a long distance. Whereas here on the right side, it is recurring around what? Subclavian artery. So the distance it has to travel to reach the tracheoesophageal groove on the right side is much lesser, but whereas on the left side, it has to travel a more distance. Please note it down. On the left side, it is going to recur around the arch of aorta, whereas on the right side it is going to recur around the subclavian. So on the left side it has to travel more distance, whereas on the right side it has to travel less distance to reach the tracheoesophageal groove. Now when it has to travel more distance, it has to go in a medial plane. Whenever it has to travel very less distance, there is no option, it has to go in a oblique plane. Okay, now recurrent laryngeal nerve, recurrent laryngeal nerve, our recurrent laryngeal nerve is going to travel posteriorly to the thyroid. It is going to run posteriorly to the thyroid and it is going to enter the larynx. So it travels posterior to the thyroid and it is going to enter the larynx. What is the entry point? Where is the entry point? And enters the larynx at the what point? It is the cricothyroid junction. So cricothyroid joint is the place. Cricothyroid joint is the place where this recurrent laryngeal nerve is going to enter into the larynx. I want you to remember this point is at the level of Berry's ligament. You already know what is Berry's ligament. Condensation of the pretracheal fascia is going to form the Berry's ligament. Now, not only it is at the level of Berry's ligament, other point is this is the point at which recurrent laryngeal nerve is at most risk of injury. During surgery. Please note it down, very important point. Okay. Recurrent laryngeal nerve can be located in the tracheoesophageal groove. There is a triangle over there. The name of the triangle is Bayer's triangle. Bayer's triangle. I have already drawn the diagram for you. Please look at it. I have drawn the triangle also. So what is this? This has to be your common carotid artery. What is the artery over above? It has to be your inferior thyroid artery. And what is this yellow color now? That has to be your recurrent laryngeal now. So tell me that boundaries of Bayer's triangle: common carotid artery, inferior thyroid artery, recurrent laryngeal nerve. At this Bayer's triangle, we can find the recurrent laryngeal nerve. Okay. Next, moving to the intercostal drainage. So coming to our intercostal tube, we are going to place the tube actually in a underwater seal. Okay, there should be a bag which is going to contain the water and this tube is going to be inserted within the water. So you can clearly see in the diagram this underwater seal where we are going to place our intercostal tube. Now, what is the site of insertion of the intercostal tube? I have drawn a small diagram for you. I have tried to draw. So, let me explain you. Suppose let me take, this is the mid-axillary line. Mid-axillary line. On one side it has to be the mid-axillary line. On other side it has to be above the level of the nipple, and it has to be below and lateral to the pectoralis major muscle. So what is the triangle of safety? Boundaries of triangle of safety. On one side it has to be the mid-axillary line. On one side it has to be the level of the nipple, and on the other side it has to be below and lateral to the pectoralis major muscle. So this is the area where I have to insert my intercostal chest tube. Right, let us write the points. Insert, we have to going to insert the intercostal chest tube at the triangle of safety. What are the boundaries? Mid. So we have to insert anterior to the mid axillary line, above the level of the nipple, and below and lateral to pectoralis major muscle. Okay, easy. Now, not only that, there is a slight variation when you are inserting in an adult or whether you are inserting in a child. There is a slight difference. In an adult, we have already seen we have to insert in the mid-axillary line. Adult A, mid-axillary line A, with in the fifth intercostal space. In the fifth intercostal space. But whereas in a child C, we have to insert in the mid-clavicular line. Okay, in the second second intercostal space. Okay, now the question is, chest tube is going to rest on dash. For this I want to draw a small diagram. This is one rib, this is the another rib. Let us assume this is the fifth intercostal space if you want. So this is rib which is present above, that is upper rib. Here it is lower rib. Now where should I place my chest tube? I can place it here or I can place it here. Where should I place? In these two. So before to answer this question, you should know where are the major structures present. Means what? Vein, artery and nerve, where are they present? You should know. So vein, artery and nerve, these three things are present over here. So if at all I am going to place the chest tube in the lower border of the upper rib, then it is going to cause injury to the structures. That is the reason why chest tube should always be rested on upper border of the lower rib. Okay, this is important. I will ask you another question. If at all I am going to do, suppose there is a patient with any rib fracture, I am going to give pain relief, I am going to give him anesthesia, okay, to the intercostal nerves. Now where I have to insert the needle? Lower border of upper rib or upper border of the lower rib? Yes, we have to insert in the lower border of the upper rib. That is the place where nerves are present. That is the reason why whenever I am going to give anesthesia to the intercostal nerves, I have to give it in the lower border of the upper rib. But here I am going to give what? Drainage, ICD. So tube I have to place it in the upper border of the lower rib. Now, how to assess the position? How to assess the position, if you ask me? To assess the position, the best way to assess the position of the chest tube means anatomically easy. Have we kept it correct means it has to be assessed on a chest X-ray. ICD how to insert means you have to give a small incision. After giving incision, you have to place our chest tube. I mean, we have to pass through the parietal pleura. We have to enter into the pleural cavity. That is where we are going to place the chest tube. To assess the position, anatomical position, whether we have kept it correct or not, it is assessed on a chest X-ray. But if you ask me, I have placed correctly in the correct anatomical position, but I want to know whether the tube is patent, whether the tube is working properly, functional assessment of the tube I have to do. Now, how can I do it? I have to observe the oscillation of water column level. Okay. If it is oscillating, then the tube is already patent and the drainage is already coming. Okay. Now, what are the various places where we are going to use this intercostal chest tube drainage? So, first thing is simple pneumo. In simple pneumo, the patient is already stable. So, I mean somewhat stable. I have time to get a chest X-ray done and I am going to confirm it is a case of simple pneumo. After that only, I am going to insert an intercostal chest tube drainage. Coming to tension pneumo is an emergency condition. I do not have adequate time. I don't have even time to get an ICD done. The first step I have to get done is needle decompression. I have to get a needle decompression done. After that only, followed by which I have to get an intercostal chest tube drainage done. Now, coming to a case of open pneumo. Open pneumo means what? There is already an opening which is present between the thoracic cavity and the outside. My aim is to make that a closed cavity, means I have to insert a three-way valve. First I have to close that with a three-way valve, then I am going to insert an ICD. Okay. Coming to a case of simple hemothorax, the patient is already somewhat stable. I can get a chest X-ray done. I have to confirm that is a simple hemo case, and after that I can place an intercostal chest tube drainage. Coming to massive hemothorax, the way it is an emergency condition, I do not have much time. I have to straight away go for intercostal chest tube drainage. Right? Now, I have already told you indications of the ICD. Now coming to the contraindication of ICD. In congenital diaphragmatic hernia, suppose this is the level of the hernia, the contents of the abdomen, intestine and all, they are going to come up and they are going to lie in the thoracic cavity. If at all I am going to insert a chest tube, it is going